A 55-year-old gentleman presented with a right inguinal hernia. Outline the principles of surgical management.
The different options include laparoscopic or open mesh repair of his hernia. Laparoscopic repair could be either in the form of a transabdominal preperitoneal approach, or alternatively totally extraperitoneal repair. The choice of surgery depends on the expertise of the operating surgeon. Laparoscopic repair can be offered as an option in this unilateral hernia, as per NICE guidelines. The guidelines recommend laparoscopic repair for bilateral or recurrent hernias. Alternative options include open mesh repair, especially if it's the patient's choice, and conservative management, with or without a truss, if the hernia is asymptomatic. The patient will need to be counseled about the small risk of incarceration, which is 0.5% per annum for direct hernias, and 2.25% for indirect hernias.
What are the qualities of an ideal mesh?
An ideal mesh should handle well and be lightweight. It should also have large pores to reduce the risk of the fibrotic reaction, causing mesh shrinkage.
What are the borders of the inguinal canal, and how can you differentiate between a direct and an indirect inguinal hernia?
Anteriorly, the border is formed by the external oblique aponeurosis. Posteriorly, more medially in the conjoint tendon, which also forms the roof of the canal, and more laterally, is the transversalis fascia. Inferiorly, the border is formed by the reflected part of the inguinal ligament and the lacunar ligament medially. Direct hernias are medial to the inferior epigastric vessels, and indirect hernias are lateral to that.
What is the outcome of inguinal hernia repair, based on the surgical literature?
Open tension-free modified Liechtenstein mesh repair has a recurrence rate of less than 1% over a 10-year follow-up period. Literature, including a Cochrane review, comparing open and laparoscopic repair, produced mixed results, but in general there is evidence that laparoscopic repair may be associated with a smaller incidence of chronic pain. Laparoscopic repair may result in a quicker return to usual activity, however. Operation times are longer, and there appears to be a higher rate of serious complication rate in respect of visceral, especially bladder, and vascular injuries.
If this patient unfortunately develops a recurrence a few years following his surgical repair, what are the available surgical options?
Utilizing a different surgical plane following a recurrence is a sensible approach. If the original surgery was laparoscopic, I would consider open mesh repair, and vice versa.
3 months following his hernia repair, which was performed laparoscopically, the patient developed ongoing groin pain that is unresponsive to simple analgesia. Briefly outline the management of chronic pain.
The key aspects of management of pain following inguinal hernia repair is to allow a period of conservative management, with analgesia within 3 months of the repair. Early imaging, via an ultrasound and/or an MRI scan, should be considered early to exclude a recurrence. Involvement of the pain team at an early stage is beneficial, as it allows consideration of various analgesic agents, including a multimodal analgesic strategy. This includes analgesics such as paracetamol, non-steroidal anti-inflammatory drugs, weak and strong opiates, SSRIs, tricyclic antidepressants, and gabapentinoids. If this fails, local anesthetic injections can be tried in a diagnostic context, but repeated injections can also be tried as a treatment option. Surgical exploration including mesh removal and triple neurectomy of the ilioinguinal, iliohypogastric, and genitofemoral nerves may be tried through either an open or laparoscopic approach. Following laparoscopic repair, the additional removal of staples should be considered.